Very good afternoon to all of you. After the excellent and exciting presidential guest lectures, we'll now be starting with our individualized sessions. The first will be on the rapid fire knee replacement session. And may I please invite the chairpersons for the session, Dr. S.V. Vaidya and Dr. J.A. Pachore, sir.
Good afternoon, everyone. And it is always a pleasure to be associated with Vikram Shah and what miracle he has done to the Indian scene. May I call upon Dr. Taufiq Panjwani, start the proceedings as a moderator, and let's get the ball rolling.
A very warm afternoon to all of you here present at this exciting WIROC MAX 2022. I would request the respected chairperson, to please call upon the panelist for today's discussion.
May I call upon all the members of the panel? I think you all are here. Dr. Kalpesh. Dr. Vikram Shah, Dr. Kalpesh Shah, Dr. Deepak Saini, and Dr. Manu Sharma. Please come on the dais. Give them a big hand, please. They're all respected and celebrated people from Ahmedabad, running an extraordinary unit carrying world recording number of knees. So I think these are the people whom we admire, adore, and hope to follow.
Just a brief introduction about the panel. Dr. Vikram Shah is the chairman and the managing director of Shalby Group of Hospitals, with 28 years of arthroplasty experience and more than 120,000 knees under his belt. To his left is Dr. Kalpesh Shah. He's a senior consultant arthroplasty surgeon, more than 15 years of experience and more than 25,000 knees. To his left is Dr. Deepak Saini, the chief consultant at Shalby Jaipur, and more than 20,000 knees to his name. And to his left is Dr. Manu Sharma. He's the consultant at Shalby Surat, and more than 11,000 knees to his name. So, the four panelists cumulatively have more than 50 years of arthroplasty experience and more than 150,000 joints cumulatively on the dais here. So, without further ado, let's start with the proceedings. And the format will be to keep it short, simple, and practical. So we would expect the panelists to give short answers and to the point and practical. Let's start with patient selection. I would like to start by asking the panelist, which has been your eldest patient by age who's undergone TKR? Dr. Kalpesh, sir?
92 years was the eldest I have operated.
And the youngest one?
Rheumatoid 38, non-rheumatoid 44.
Anyone in the panel operated, Dr. Vikram, sir?
At our center, my youngest patient is 17 years old male. I'm suffering with ankylosing spondylitis, which is very almost bedridden patient. And my eldest one patient is 92-year-old male. And good thing was, the patient asked me, "Ki sir, 20 saal wala dalna hai isme." So he is so motivated patient.
Really speaking, when you operate young patient, you have to see the amount of disability. But totally disabled rheumatoid patient is there, age is no bar. You can do it at 20 years. And upper age, it is very important that you see some years of life in that person. So whatever age is there, say 94, 96, but if you see 3-4 years, you should do it.
I ask you, Vikram, any problem with implant selection and vis-a-vis younger child and 20 or below?
See, implant selection doesn't matter. How good job you are doing is more important.
Say, do you get well-fitting sizes available in the market?
Yeah. All sizes.
Have anyone on the panel denied a patient because of higher age?
No. But because of comorbidities, yes. When anesthetist is not ready to anesthetize, how you are going to do it?
So, coming to anesthesia, and that is an important patient selection optimization and patient selection criteria. What is your patient with a creatinine of 3, stable on medical management, not on renal dialysis? And age of the patient is 58 with grade 4 osteoarthritis. Dr. Kalpesh, do you have any special things in mind when you see these patients in the outpatients?
Yes, there are few things we need to give extra considerations to. Patients with chronic renal disease, especially higher grade, grade 4, 3 and above, they've got twice the rate of mortality than normal and more than 213% chances of complication. So you need to discuss this with patients and take consent accordingly. Second, when you are operating, you need to take care that you don't allow hypotensive anesthesia, because hypotension will further damage the kidney. In coordination with nephrologist, you optimize the patient, see the bicarbonate levels and optimize the patient. And doses or medicine dose needs to be adjusted accordingly. And post-operatively, you are not going to be able to give a lot of analgesics. So take care that you don't leave these knees tight. So that is what we take care. All said and done, still chances of infections are slightly higher.
Okay, and if the patient is on dialysis and on active dialysis, would you offer them a knee surgery at that stage?
If patient needs knee surgery, yes, we will have to offer. I would prefer if patient is in near future, patient is able to get renal transplant, I will wait for some time. Otherwise, I'll have to give offer the surgery. In those patients, I use antibiotic cement when patient is on the dialysis.
Okay. Dr. Manu, if the patient has already undergone a renal transplant,
so if the patient has already undergone renal transplant, we just need to involve the specialist, the nephrologist, and anesthetist also to take care of avoiding the nephrotoxic drugs, basically. And if needed, we have to adjust the doses of the drugs which have renal clearances. And fluid is important. Over fluid and under fluid, there's all has to be taken care so that patient gets a good result. And also a little explanation to the patient that you will need a longer therapy or longer,
these patients are already on immunosuppressant drugs.
Yes.
So, is there any change in the antibiotic protocol that you will give to these patients, or do you use the routine?
A little longer duration of antibiotics and observation of the CRP levels, and clinically seeing the patient more number of times than we usually see the patients.
All right. So, if the patient is a known case of rheumatoid arthritis and is on a gamut of drugs, what is the current thoughts of the panel on methotrexate? Do you stop them before you advise knee surgery?
Initially, we were stop all the DMRDs, but nowadays we operate our patient with DMRDs. But of course, biologicals and other drugs we have to stop before one cycle has to be stopped before the surgery. So DMRD we continue DMRD with.
So methotrexate you don't stop at all before surgery?
Yes.
And if the patient is on biologicals for rheumatoid arthritis, then you make it a point that one cycle is stopped.
Yes.
Okay. How about clopidogrel, Dr. Kalpesh, sir?
I stopped clopidogrel 5 days before the surgery.
Okay. So if the patient walks into the outpatients, then you plan the surgery for the next week and not in the same week, is it?
2 days are sufficient actually. 48 hours are sufficient for cold.
Okay. So Dr. Pachore, would you like, what would be your thoughts on this, sir?
There is no question that methotrexate can be, no question. Only thing is biological drug you must start minimum one cycle. They are the problematic. And clopidogrel, what Vikram says is 2 days are enough. but you will have to take the consent of the why this property is not his.
Right, sir. Okay. So once the patient is selected for surgery and once the patient is admitted, do you advise long leg scanograms, long leg standing X-rays for all the patients for planning?
Me?
Yes, sir.
Yeah. No, I think my radiologist is strictly told to have 12 by 15 3 films. One limb standing AP, otherwise AP, lateral and patellofemoral. That's all. Unless there is multi-level deformity, unless there is some fixation done, some fracture treated, then scanograms help, but they are not exclusive.
All right. So as a protocol, anybody on the panel does long leg X-rays as a protocol for all the patients?
Not for all.
For all, but I think with sciatica deformity.
Only in patients who have obvious extra-articular deformities or have been operated previously. Dr. Deepak, how about skyline views? Do you do this? Do you do that for all patients?
Yes, we do a skyline view in each and every cases because it provides a good knowledge about patellofemoral articulations and patellofemoral arthritis, and it also provides the good the thickness of patella you can measure in this view, so that you can decide whether you have to do patella resurfacing or not. So the couple of things are very important. So in each and every cases you have to do skyline view.
Vikram sir, you have thoughts on this?
The protocol, we do all the X-rays, epilateral and skyline.
Right, sir. So now the patient needs bilateral TKR. Okay. What I would like to start with Dr. Vaidya. What percentage of your patients you do single sitting bilateral TKR?
From 2013 onwards, when American Association of Hip and Knee Surgeons published a white paper citing the mortality rates and cardiac complication as about 2.3% and up, and they are recommended not to do it. I do serum albumin of every patient. I admit them. There is a 7 days package given to them. If I operate first knee on the Monday, next is on Thursday after confirming albumin is more than 3.5. Never both together after 2013. There are strong reasons. I lost a patient.
Vikram sir, your thoughts on this, sir?
We do nearly 50% of patient bilateral together, but we make sure that all medical parameters are good enough and they are lesser than 70-year age.
Dr. Kalpesh, you have thoughts on this? Single sitting bilateral TKR for...
Yes, we do single sitting bilateral, but we have our protocols set. Patient under age of 70, hemoglobin level, nutritional level good, and no medical comorbidities. And patient with BMI less than 30.
So you just spoke about BMI, Dr. Kalpesh. Is what your cutoff for doing a TKR for any patient who's obese?
There is no cutoff. We do TKR in obese patients also.
Even in morbidly obese patients with a BMI
Yes.
of above 40?
Yes.
Okay.
The highest weight we have done is 164 kg. Second highest we have done is 162 kg. Not a problem. But you know, experienced surgeon has to do it. First 1 foot incision because thigh is too big. So it takes double the time.
I would like to take this opportunity to ask tips and tricks for a novice surgeon who's going to operate a patient with a BMI of 43. What would be the things that you would tell the patient, the surgeon, before he walks into the OR?
First is to take adequate incision. Don't go for short incisions, minimally invasive. Take adequate incision. And second is you need good assistants, experienced assistants, because exposure is difficult in these cases. You might not be able to evert the patella, so take care of extensor mechanism. There are chances that you might damage that. And the alignment, limb alignment, we should take care because normally we tend to keep 6 to 7 degrees of valgus alignment. In these patients, actually the dynamic alignment is different than the routine people. So if you keep 7 degree of valgus, they might walk with a knock knees. So you have to keep it less valgus, like 1 to 2 degrees or 3 degrees of valgus. That is what we take care.
Dr. Vaidya, you have to add something?
I think I agree with Kalpesh on most of the points. I think patella is an issue. I additionally pin the tibial tubercle because it's going to be the deciding factor. You don't realize, but one push for the extra flexion, the fat is more distributed high and calf, you have a problem.
Right. So the take home point here is for, yes. Yes, yeah.
Questions? Dobutamine stress echo is a protocol for bilateral TKR, yes or no? Okay. And role of tibia rod in morbid obese.
Roll of, sorry?
Pardon?
Tibia extension rod in the morbid obese. Your comments?
No. We don't use. Until unless there are no defects.
I always used rods for tibia and femur both.
In a morbid obese patient, for tibia and femur, both you use the rod.
I think it's not necessary. We have our own publication of morbid obesity. If you go through the literature, and we have never put on any extension rod in the tibia, unless absolutely you have an additional stress fracture, then that is a different phenomena. Yeah.
But not for obesity.
Not for obesity, not necessary, not
Right.
necessary.
Right.
But today's implants are really good.
So the take home point here is that if you are going in to operate a patient who's obese, don't try to evert the patella. Try and pin the patella tendon so that you save the extensor mechanism, and be as liberal as you can with your knee incision. I think those are the three main take home points here. Now, I would like to ask Dr. Manu Sharma about his take on patients who will undergo TKR with Parkinsonism. So nowadays, a lot of patients with neurological problems are coming elderly. So what is your take on patients who comes with Parkinsonism?
You see, we are routinely doing TKR in patients of Parkinsonism. First of all, neuroconsultation is important, and the patient should have controlled Parkinsonism. I mean, patient is walking, patient is having a stable gait. So I don't think there is any problem in doing knee replacement. But yes, if a patient is having very unstable gait, and we need to explain to the patient that what you are going to get through the surgery. I mean, pain relief you will get, but you might not be walking like other patients are walking if there is not so much of control in the Parkinsonism. So taking this care, proper counseling of patient.
You have to moderate the expectations.
Yes,
in
yes, we
patients
do
with
need to moderate the
Parkinsonism.
expectation.
Sir,
It might worsen also with due course of time.
Sir, you have some points to add? Vikram sir?
You have to really see patient critically and clinically that patient has come for problem of balance or pain. And a number of times neglected patient coming in wheelchair, and they have large problem of untreated or not properly treated Parkinsonism, and they are not good cases to be operated. So it is very important that you select your case properly and get them neurologically treated first, whether it is a problem of balance or pain. And second thing is your physiotherapy protocol should be very strong compared to what you do it in regular osteoarthritis. They need long-term good physiotherapy to keep their quadriceps.
Intraoperatively, would you leave these patients in a little bit of hyperextension, a little bit of extension laxity?
No,
because you expect them post-operatively to
see,
contract?
when you operate a male patient, you do it in a proper way. You don't leave it lax also, you don't leave it tight also. But you need lot of physiotherapy for these patients for them to walk properly. More than double or 3 times than routine osteoarthritic patients.
Yes. Dr. Pachore, would you like to?
One additional thing for these patients, I think post-operative physio, what Vikram has pointed out is a night splintage, because they are likely to go into again flexion deformity. And post-operative pain management is very important for these patients. They will require longer period. And PS implant will be my choice. I don't know about Vikram, what you would like to have. That will be CR knee are not good for this.
Right, sir. So, let's go to a primary knee. We are short of time, so I will quickly skip through some slides. So, a primary knee. I would like to just show a raise of hand. How many use a tourniquet for a primary knee on the panel?
Rarely.
Always.
Not in all cases.
We don't use tourniquets unless and until anesthetists say that they cannot, the BP is a problem, cardiac patient is there and they have to keep BP high. Otherwise, we don't use tourniquet.
But do you advise the anesthetist for hypotensive anesthesia at the time of surgery?
Routine cases, yes, we keep BP around 100, between 100 and 110. So that is all.
Right, sir. Okay. I'm sure, as a matter of fact, the panelist, we know that the panelists do a medial parapatellar approach for all their cases. But I would like to know, Vikram sir, your thoughts on subvastus approach. What do you think is subvastus approach?
See, I have never done it, so there is no way I am going to opine on that. But what I personally feel is you do surgery nicely, cementing nicely, you balance your knee. Now, whatever approach you take and you are able to do it nicely, do it. But I personally feel that why it is not adopted in last 20-25 years world over as a standard, it is because there are some issues with that approach. That is what I believe. Why everybody is not doing it.
Correct. Your thoughts, when would you consider, Dr. Kalpesh, when would you consider doing a lateral parapatellar approach?
Any valgus knee which is not correctable, I will go with lateral parapatellar.
Okay. And when you do a lateral parapatellar approach as opposed to medial parapatellar, which we are usually used to, what are the things that you would have to really remind yourself and keep in mind?
Nothing. See, that is you yourself answered the question. You are used to medial parapatellar, so you are doing it easily. Now, the problem with surgeons is that they use lateral parapatellar in bad cases. And in bad cases, they will find this approach difficult. So they term this approach as difficult approach, and they have to think about while doing it. But if they make it a point in routine valgus also, which are not correctable, to use this approach is as easy as medial parapatellar.
Okay. Dr. Pachore? Yeah.
I think this is a true indication for a valgus knee with a cablish, that is lateral parapatellar approach is what Kalpesh said was a fixed valgus, which is non-correctable under anesthesia, not clinically. Because most patients will not allow you, number one. Number two is very important, is lateral subluxated or dislocated patella. You will be able never realign with the middle approach. That is the indication as far as I am concerned. For
Dr. Vaidya, you have thoughts on this? Lateral parapatellar approach?
I've never done it. I'm very happy with the way I'm doing it. But I think I agree with Pachore that you'll have a better and finer patellofemoral balance re-established. That's one. Because inherently there has to be atrophied lateral condyle of the femur. That adds to your woos. So I think the way he described it, the fixed valgus where get patellofemoral balance back to normal is what is required.
Right, sir. So, coming to stiff knees, okay, I would like to, ask Dr. Deepak this. Dr. Deepak, what is your approach to a patient with a stiff knee when you enter the theatre?
Stiff knee are really difficult to expose because, my tips and tricks for these knees are, because you have to examine your knee before anesthesia and after anesthesia. Most of time, the patient having fibrous ankylosing. So, as earlier stated, the patellar pin should be used, patellar quadriceps knee approach you have to know. In rare conditions, you should know about the tibiotubercular osteotomy to expose your knee. In fibrous ankylosing, I think we usually don't use this tibiotubercular osteotomy, but we gradually release all adhesions like quadriceps, fibrosis, lateral gutter, medial gutters, and then gradually flex it. Once you achieve 90 degrees of flexion, then everything is in your hand. So, but the only important point is you have to take care of your quadriceps mechanism, because this is the only thing which can be ruptured during exposure of stiffening.
Would you ever consider taking your tibia cut in full extension?
Yeah, we usually take freehand tibia cut, so it is very easy for us. Once you remove 5-6 mm chunk freehandly in extension, then it gives a good way to flex your knees. This is very important things.
Yeah, but the caveat is be very careful with your...
Yes, of course. You need to take a lot of care.
One thing can be done in those cases. You can have a CT, you can measure the length of the tip, what we are cutting. tibia and measure the saw blade. If we are doing that freehand in extension, we need to be very careful about the length of tibia we are cutting. And the last, we can leave small amount of bone to be cut by osteotome.
Yes.
I'll be very careful in a patient where flexion deformity is 40 and then further 20, 30 is possible. This patient, I'll monitor pulse ox, make sure deep dorsalis pedis is also monitored, and I'll take my tibia cut in whatever position it is without trying to do things, because release at both ends, tip there and banana peel down there.
Okay, so just a show of hands here. What is the preference for a primary TKR? CR, how many on the panel would do a primary CR knee for a primary TKR? Deep dish or a cruciate sacrificing implant? PS? Okay, so it's an all PS panel here. And fixed bearing, how many would be fixed bearing on the panel? And how many prefer rotating platforms? When would you think that a rotating platform would be?
Male muscular patient around 50, activity level very high, always rotating platform.
Okay, and Vikram sir, your thoughts on high flex designs? What is your take on the high flex designs that are on the market?
High flex joints were available in the market by several companies and all of them have been withdrawn because there are a number of papers now showing very poor result of high flex. RPF or high flex zipper or all those have gone out now. So I never did it and I was lucky not to do it.
I will admit here, it was Vikram who told me, if you want to spoil your practice, use RPF.
All right, so this is a case of rheumatoid arthritis, 40-degree FFD, post anesthesia. How much of this deformity are you going to correct per op and how much would you leave it for post op? Dr. Kalpesh, you have thoughts on this?
General rule is 30-30-30. Before anesthesia 30 degree, after anesthesia some correction will be 30 degree, and after the anesthesia, during surgery we'll correct the remaining 1/3. So the main point is that if there is severe, like in rheumatoid patients, there is severe flexion deformity more than 30 degrees, the neurovascular structure is shortened, it is contracted. So in those cases, after one level, no matter how much distal cut you take additional, the knee during trial you will not feel that it is straightening. It is because of the tight structure. So once you create adequate extension gap, you leave it at that, and post-operatively it gets corrected during physiotherapy session.
So you will be happy with leaving a 10 to 15 degree FFD when you come out of the theater in a rheumatoid arthritis?
Yes, but that should be with adequate extension gap and because of soft tissue and not because of the bony block.
All right. Dr. Manu, any thoughts on that?
Yeah, I agree with him. We can leave small amount of extension tightness, but yes, what he said, I mean, it can be posterior tightness, and there should be space for the tissues to relax with physiotherapy and bracing. So it usually corrects, and actually in rheumatoid it corrects.
All right. Again, a show of hands. How many in a routine primary TKR on the panel will use a drain? Okay, from the audience now, a show of hands. How many in a routine primary TKR will use a drain? Okay, so that's more than 50% of the. How many use a urinary catheter for all patients? And how about the panel?
We are using urinary catheter in all bilateral cases, but not in unilateral cases.
In all primary knees, Dr. Vaidya? Unilaterals also. Okay, now just about a little bit of post-operative management. Dr. Kalpesh, what would be your post-operative pain management protocol?
Pain management, we inject, actually it starts with pre-operative, but we give the preemptive analgesia also. During surgery, we inject cocktail also with ropivacaine. Post-operative, we don't use adductor canal blocks or IPACs. Post-operatively, after an hour or so, we give one steroid dose. and then we give diclofenac injections for 1 day and centrally acting like nalbuphine or tramadol. And from next day onwards, we shift them to oral non-steroid anti-inflammatories and centrally acting like tramadol. That's all. But I would like to stress one point here, that post-operative pain management starts with your surgical technique. If your surgery is good, you are managing your pain nicely. If you keep, your surgery very lengthy, improper or not proper soft tissue dissection, you are going to have a lot of post-operative pain.
Dr. Pachore, you have thoughts on that?
The same thing, except that the cocktail injection should be very properly. It should be in the medial and lateral, both posterior capsular area, which we already published in the literature. Because just don't do it only on the medial side, and only center 1 centimeter can leave and do this. And they have a pain score very extremely good. And second important is the dexamethasone, which has reduced the post-operative analgesia, and as well as CRP levels of these patients is on the lower side. The inflammatory phenomena is much lower.
So dexamethasone
at the time of incision.
at the time of IV, at the time of
IV.
Okay. What would be your dosage for this, the dexamethasone at the time of incision? 1 gram. Okay. You have thoughts on this?
In my cocktail, Canacort always 2 ml. Rest all antibiotic and everything, propivecin is the same.
So just in the interest of time, I'm skipping a few slides, and I would like to get some thoughts on newer advances. Dr. Vikram, what is your thought on the new coating which is available?
Well, it has improved coefficient of friction with pulley. So, weakest point in any joint is a pulley. When the coefficient of friction goes down, it really helps. Really works well in vivo and vitro both. There are a number of studies in vitro about coefficient of friction.
So given an option, would you?
I would go for coated implant.
Coated implants. Yeah. And how about vitamin E polys?
Well, vitamin E poly basically is very good for hips and very good for CR knees. As far as PS knees are concerned, vitamin E poly little brittle, and not many companies are that's why producing. We are all PS knees users, and post-cam mechanism gets a lot of stress, and if it's brittle, it will break. So, most of the companies are also making for CR knees vitamin E poly, but not for PS. There are a lot of in vitro studies going on, and if they are able to produce vitamin E poly good enough for long term for post-cam mechanism wear, then it will come. But vitamin E poly is very good for hips or CR knees.
Okay. Dr. Vaidya, your thoughts on this?
Well, I think I would wait for a substantial evidence to come up, because all that new, as we had, history has taught us that all that new, if we adapt too fast, it is going to lead to more complications. I think this brittleness point, I totally agree with Vikram. As a matter of fact, I look upon him to guide us as to which are these materials are really of great use and which are not.
Right, sir. So last question about, and this will, I think I'll start with Dr. Vikram sir. What do you think is the future of joint replacement in India?
Well, 20 years ago, I used to say that India will be doing a couple of 100,000 knees in 10-15 years, which we are doing now. In 10 years from now, India will be doing 2 million joints, hips and knees. So be ready for that. Are you ready for that?
I think it is premature for someone as naive about these matters when you sit in front of Vikram Shah and talk about numbers, I think he has made an art and science and business out of it, and he possibly knows the best.
So 2 questions from the audience, if anybody would like to make a comment. Okay, one question. All right.
Thank you.
Make a comment.
I thank the panel for being here, Vikram and his team, and Taufiq and Dr. Pachore for being elderly guidance. Thank you.
Thank you.
I would like to make a comment
Yes.
on lateral